We are going to present this lecture in the form of different case scenarios or different clinical scenarios in order that we may learn how to diagnose and treat aortic regurgitation according to daily practice. First case is a 62-year-old man who has a recent onset of chest pain and breathlessness. His blood pressure is 170 over 90 mm mercury. His oxygen saturation is 90% on room air. His temperature is 36.5 degrees Celsius. There is an early diastolic murmur heard over the second right intercostal space. He has bilateral basal lung crepitations. His blood tests show hemoglobin of around 14 gram per deciliter, urea of 50 mg per liter, creatinine of 1.5 mg per liter, cholesterol of 289, and triglycerides of 194 mg per liter. Which of the following is most likely? That this man have acute coronary syndrome, or aortic dissection, or pulmonary embolism, or dissecting aortic aneurysm? The correct answer is number 4. It's a dissecting aortic aneurysm, and the explanation is that this man has a recent onset diastolic murmur over the aortic area with elevated blood pressure and lung crepitations. After looking at this electrocardiogram, what is your comment on this ECG? Is it sinus tachycardia with left axis deviation? Is it incomplete left bundle branch block? Is it left ventricular hypertrophy and strain pattern? Or is it ischemic ST and 2F changes? The correct answer is number 3. It represents left ventricular hypertrophy and strain pattern since it fulfills the criteria of left ventricular hypertrophy. What is the best diagnostic investigation in case of dissecting aortic aneurysm? Is it chest X-ray, or transthoracic echocardiography, or transesophageal echocardiography, or CT scan chest with contrast? Which is the most sensitive and specific? The correct answer is number 4. It is CT chest with contrast, the best diagnostic investigation in case of dissecting aortic aneurysm, with sensitivity and specificity of 99%. That's an X-ray of this man representing wide mediastinum, indicating that the patient may have dissecting aortic aneurysm. That's transesophageal echocardiography showing flap in the aorta in both views, as we can see, with a false lumen containing spontaneous echo contrast indicating the presence of thrombi in the false lumen. That's a CT chest with contrast showing also the flap inside the aorta with two lumens, the false lumen and the true lumen, as we can see, with different echogenicity, indicating that the false lumen contains thrombi. What is the treatment of choice of acute aortic dissection? Is it control of blood pressure? Is it oxygen and sedation only? Is it surgical intervention or antithrombotic therapy? Definitely the correct answer is surgical intervention, as the mortality rate is very high, especially in the first 48 hours, so early surgery is highly indicated. Our second case. A 27-year-old female patient discovered to have systolic hypertension of 180/70 during her pre-employment examination. She has prominent neck arterial pulsations. Her cardiac examination revealed left ventricular hyperdynamic apex with decrescento diastolic murmur on the second aortic area and apical mid-diastolic murmur with normal first heart sound and second heart sound with no additional sounds. Which of the following diagnoses is most likely? Does she have rheumatic heart disease, mitral stenosis, and pulmonary regurgitation, or chronic aortic regurgitation, or severe anemia, or coarctation of the aorta? The correct answer is chronic aortic regurgitation. So, what is the possible etiology in that scenario? Is it rheumatic heart disease? Is it aortopathy due to Marfan syndrome, or endocarditis, or degenerative aortic valve? The correct answer is aortopathy due to Marfan syndrome. You have to remember that acute aortic regurgitation may be due to infective endocarditis, dissecting aortic aneurysm, rupture of the aortic leaflets, trauma, or myxomatous valve. While chronic aortic regurgitation may be due to either congenital or aortopathy or acquired. Congenital as in bicuspid valve, aortopathy as in cystic medial necrosis, collagen diseases like Marfan syndrome or Ehlers-Danlos, or osteogenesis imperfecta. Acquired as rheumatic heart disease, dilated aorta as in hypertension, which is the commonest cause, degenerative connective tissue disorders like ankylosing spondylitis, rheumatoid arthritis, Ritter syndrome, giant cell arthritis, and in the past we could see aortic regurgitation in chronic aortitis due to syphilis. In aortic regurgitation, you always have to comment on the pulse pressure. What's your comment on the pulse pressure? Is it normal? Is it small? Is it big? The correct answer is big. You can't diagnose aortic regurgitation without the presence of big pulse volume. In cardiac diseases, when we comment on the pulse, sometimes we find it a hypokinetic pulse or a hyperkinetic pulse. The hypokinetic pulse is defined as a weak pulse which signifies narrow pulse pressure. What's pulse pressure? Pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. While the hyperkinetic pulse is a bounding pulse signifies high blood pulse pressure. Hypokinetic pulse may be due to low cardiac output as seen in cases of shock or congestive heart failure, or may be due to hypovolemia or valvular heart disease such as tight mitral stenosis, severe aortic stenosis. While hyperkinetic pulse may be due to low peripheral resistance as seen in fever, anemia, thyrotoxicosis, AV fistula, Paget disease, beriberi liver cirrhosis, or increased stroke volume as is seen in anxiety, exercise, complete heart block, or aortic regurgitation. Decreased distensibility of arterial system as seen in atherosclerosis and hypertension. The prominent neck arterial pulsations in case of aortic regurgitation is known as water hammer pulsations, Muller sign, Corrigan sign, Trope sign, Duroisier sign. And the correct answer is number 3, it's Corrigan sign. Remember, there is very wide pulse pressure with associated signs. Water hammer, collapsing pulse, big volume, rises rapidly and collapses rapidly. While Corrigan sign is visible carotid pulsations. De Musset sign is head nodding with each pulse. Muller sign, visible pulsation of the uvula. Trope sign also caused pistol shot femoralis. Loud sound noises heard with the stethoscope over the femoral artery due to sudden distension of collapsed arteries. While Quincke's sign, visible capillary pulsation in the nail bed. The Duroisier sign Systolic and diastolic bruit produced by compression of the femoral artery with a stethoscope. The systolic bruit is due to rapid flow of blood to the periphery, while the diastolic bruit is due to rapid regurgitation of blood to the heart. While Hill's sign is that systolic blood pressure in the lower extremities is higher than blood pressure in the upper extremities by more than 20 mm mercury in mild aortic regurgitation and 40 mm mercury in moderate aortic regurgitation and 60 mm mercury in cases of severe aortic regurgitation. If you have to select one investigation that would help you in the management of this aortic regurgitation, what will be the investigation of choice? Is it electrocardiogram, is it echocardiogram, or cardiac catheterization? The correct answer is echocardiography. The echocardiography determines the degree of aortic regurgitation and may also determine the etiology of this problem. Finally, you have to remember that chronic aortic regurgitation can be well tolerated for many years and is associated with good prognosis. 5-year survival is 75%, while the 10-year survival is 50%. Prognosis worsens as symptoms develop. Asymptomatic patients of aortic regurgitation only need follow-up, while symptomatic patients, we start with medical therapy, and which includes prophylaxis against traumatic activity and infective endocarditis. Symptomatic treatment of congestive heart failure may respond to medical therapy, as in loop diuretics ACE inhibitor. Patients of aortic regurgitation need surgical intervention in case of presence of symptoms not responding to medical therapy, or progression of left ventricular dilatation, or declining left ventricular function. As we can see, this is a diagram representing the guidelines of the management of aortic regurgitation. When to refer to surgery and when to keep the patient on medical treatment and just follow up. Our third case. A 52-year-old man known to have moderate to severe aortic regurgitation since 15 years, and he was on irregular follow-up. Recently he presented with rapid palpitation and progressive shortness of breath. His blood pressure is 150 over 70 mm mercury. His oxygen saturation is 92% on room air. His temperature is 36°.5 Celsius. There is an early diastolic murmur heard over the third left intercostal space with pansystolic murmur over the apex. The patient has bilateral basal lung crepitations. What is the possible cause for the development of shortness of breath in this 52-year-old male patient? Is it natural progression of the disease? Is it endocarditis? Is it atrial fibrillation? Is it myocardial infarction or chest infection? The commonest cause is atrial fibrillation, and the patient developed rapid palpitation. When you take a look at this electrocardiogram, what is your diagnosis? Is it frequent atrial premature contractions? Or is this electrocardiogram normal? Or does the patient have controlled atrial fibrillation? Or does the patient have right axis deviation? As you can see in the electrocardiogram, the proper diagnosis is controlled atrial fibrillation. What is the most important next investigation after X-ray chest in this patient? Is it contrast aortography? Is it transesophageal echocardiography? Is it transthoracic echocardiography? And the correct answer is number 3. It's transthoracic echocardiography. Our final take-home messages are: acute aortic regurgitation may be a complication of aortic dissection and needs surgery. Multi-slice aortography is diagnostic of aortic dissection. The etiology of chronic aortic regurgitation may be congenital or acquired. Chronic aortic regurgitation may be asymptomatic or symptomatic. AVR, aortic valve replacement, is indicated for symptomatic aortic regurgitation or asymptomatic with impaired systolic function or progressive dilatation of the left ventricle.